And now we're going to feature Dr. Juan Arias. I learned about Juan by Facebook, actually. I was looking at his pictures, and they always impress me. Right now, you are going to see a very outstanding presentation of periodontal surgery and related to aesthetics, and I'm sure that you will really enjoy it. So thank you very much. Here's Juan Arias, and he will be setting up his computer in order to present.
Ready to go? Dr. Arias is from Spain. Welcome. He's University of Madrid, Master in Periodontology in Madrid, also aesthetics. He went on into the University of Europe in 2005 to 2009. It's all in Spanish that I'm reading right now, by the way. Okay, and into the Society of Española in Periodontology. So he's a periodontologist and specialty in implants. Thank you.
Well, hello. I think it's okay now. First of all, I'd like to thank the American Academy, the Scientific Committee, and Daniel Ochoa for their invitation. It's my honor to be here, and I'm very glad to be here and show you some of my cases. My favorite topic is periodontics and implant dentistry, and that's all what we're going to talk about today. First we'll start with it. I'd like to make a small reflection on what I think makes the difference. We've got different situations, and all of them, I think that the difference made between if we've got enough tissue, if we have tissue or we don't have tissue, okay? We're going to talk about the reconstruction, and there's some situations in which the tissue permits us create a natural aesthetic zone again, and there's some other situations in which we don't have tissue and we have to make the reconstruction of everything. We have to think that when we're placing an implant, we're not just placing an implant, we're reconstructing the periodontum, the whole periodontum. So we have to think about papilla, we have to think about the hard and the soft tissue, the presence or the absence will make the difference. So we've got different cases, we've got different situations in which if we have enough tissue, we can try to work with the provisionals until the gingival position is the one we really want to. Yesterday I was here with a lecture of Dr. Van Doren and Victor Clavijo. They were talking about how they can guide the tissue with the final crowns. That was amazing. It's an amazing lecture. They're amazing clinicians, and I learned a lot about them. But today I still work with the provisionals. I still try to guide the tissue with the provisionals. I'll try to make the things that they try to make, but I think that for my day, provisional is the way I work. So if we have tissue, we just have to guide the tissue to the position that we really want to. The problem is when we don't have anything. Okay, there are some situations in which we don't have any kind of bone. We have to reconstruct the periodontum. And in this situation, sometimes just think about the papilla. It's the last thing. First of all, we have to reconstruct everything. And once we have it, we'll try to place the papilla wherever we really need to. So I'm going to try to divide the lecture in two parts, when we have tissue and when we don't have tissue. If we have tissue, I think it's quite a bit easier. We can jump one step, which is reconstructing everything, okay? This is a case, a young, nice woman in her office with this situation. She had a problem in that 11, and she finished, when we arrived to this moment, she has finished with the surgery procedures. The implant is placed, and the hard and the soft tissue are redone. And with the provisions, we can try to guide the papilla and recreate the natural feston. Okay, we will go all the way with the pressure until everything goes to the place that we really want to. That's the way we work with the provisionals. We can make lots of different types of provisionals. Sometimes I do work with these natural provisional crowns. I like them a lot because they can give you the advantage that it will maintain the position of the tissue where you find it. So we can make difference between if we've got a patient with no tooth we have to guide all the tissue. But if we are going to make the extraction and afterwards the placement of the implant, we will try to maintain the emergency profile wherever it was at the beginning. So in this case, this is would-be Spanish player, and I like this black and white picture because it shows you the texture of the tooth. It's a real difficult tooth to redo. So I like to show the color and see the texture and the way it's done. So this patient, he had a fracture here in 21. You can see here the fistula. So we did have to make the extraction, and it's important to notice here that the placement of the tooth here is in a little bit apical position. So there's no papilla here, there's no good papilla here, no good papilla here, so we can work with the emergency profile just to try to remake the papilla in the position that we really needed to. So we did the extraction. You can see here the fracture, even though I think that you can see it even better here. So we did the extraction and we did the normal procedure. We cleaned everything. We cleaned the alveolar bone there, and we placed our implant in a normal situation. We didn't have any problems with the hard or the soft tissue. It was really good place, so we just wanted to maintain it there. So we also placed hard tissue graft, and also we did have enough space to place a soft tissue graft. This tissue was coming all the way from the tuberosity, so that kind of tissue gives us a lot of volume, and that volume will maintain, and even though that volume will go even bigger than what we have at the beginning. We'll see how it works. So we placed also our zirconia abutment there. This is the same moment of the surgery. The zirconia abutment is going to give a lot of stability to the graft that we have underneath. With the zirconia abutment and with the provisional we're going to develop, it will maintain the stability of the graft with no problem. We won't have to give any kind of suture there. This is the lateral view, the position of the zirconia abutment and the implant, the emergency of the implant, and this is what I call the plan B. The plan B is done because of the lab. They prepare it just in case the natural provisional doesn't work, because sometimes it's kind of difficult to prepare it. We have to cut the root, and we have to try to empty all of it, all what's inside. We have to empty it, but we have to try to give enough space so it can maintain that situation long term, just for the osseointegration of the implant. So we work a lot with it. We try to make it as lower as we can. You need a lot of patience to do it, a lot of time sometimes, but it's not that difficult to do it until we get to something which will look more or less like this. It's just a provisional, but it's a natural provisional that will maintain the emergency profile that we had at the beginning. This is the way it looks. You see, you have space enough there to place it on the zirconia abutment with no problem. So that's what we do. We go all the way there and we place it. And see how the zirconia abutment and the provisional will give a lot of stability to those grafts we've got underneath it. So this is when we finish the surgery. That's the same day of surgery. We have changed the position of the 21. We have placed it in a little bit apical position. So I think we're going to work with the relation between the bone and the contact point. So the papilla will grow. Just see how 6 months afterwards, the papilla will come with us. You see, 6 months afterwards. And see the lateral view and see how the tuberosity graft will give us volume. This is in the same moment of the surgery, and this is 6 months afterwards. We've got much more volume there, so it works good. And the X-ray, you can see it here the same day. 1 month and 6 months afterwards, it's placed. So the problem now is with the lab. He has to reproduce this texture. It's a very, very nice tooth. I didn't want to make any change. I wanted to maintain that provisional forever. That was difficult to do. We had a lot of tries, and it was never the same. But, well, they did their best. They worked a lot. That's a Spanish lab. They work real good. Finally, they did this crown, and we removed the provisional. See how the tissues surrounding the zirconia abutment and the provisional were 6 months afterwards. It looked real good, really healthy. So we worked on. We placed our provisional there, final crown, sorry. See the volume we've got there. It's maintained. And see how the case was developed from the beginning with the position of the tooth, how we changed it the same day of the surgery. No suture, no problem, good stability of the grafts. 6 months afterwards, the papilla was growing there, and 2.5 years after, with the final crown. I know it's not the same as the provisional. Sometimes it's really difficult in these cases to get the same crown, but the patient was really happy with that. He had no problem. He loved the crown. And this is how it looked with the white aesthetics. It looks real good. So this is the part when we're talking about the presence of tissue. If we have tissue, sometimes it's easier. We just have to maintain it. We don't want to make any change. We have to preserve the position of the papilla. Maybe we can make some small changes, but if we have it there, just try to maintain it. But sometimes we don't have anything. And this is the big problem. We have to reconstruct everything. So if we talk here about provisionals and papillas, that's kind of scary for me. First, I'd like to talk about how to place the implant, and then we'll talk about papillas. But this is not the case I'm going to show you. This is just a slide. It did not end as good as the other one, so better not to show it. But I'm going to show you this one. Okay, this one's good too. Okay, she is a nice young woman in Spain, and she came very depressed to our office with this situation. When I saw her first, this was the situation, and I was really scared because I knew she had an implant here in 11. And when I saw this situation, I thought, okay, I have to remove the implant, and I have to take also 12, the lateral incisor. I have to take it out because everything must be lost. It looked really scary because how can we talk about redoing this papilla? It's difficult for me to think. If we have to take both of them, I'll have to make a great regeneration, the vertical regeneration, and afterwards I'll have to work with that tissue to recreate papilla. So it's kind of difficult. So this was the lateral view. She was very upset with this situation. She had an implant there, and that implant was placed about 4 years ago, but her dentist saw that there was some bone lost surrounding the implant, so he did a regeneration surgery 4 months ago. So the regeneration surgery was not good, and this was the aspect she had. So when I took her the X-ray, I saw that it did not look like the clinical way. It was not that bad. You see, you've got some bone lost here, but not for this hole here. The lateral incisor was not that bad, and the implant was also on the nasal bone there. So after thinking about it and analyzing the case, I saw that there was a big periodontium here. It was very healthy, and it was quite resistant for the movements that we could do. So I talked with her and I said, okay, I'll try not to make the extraction of the implant or the extraction of the lateral incisor. We're going to see how they work with the treatment. And in order on how we finish, we'll decide what to do. She was very happy with that because she didn't want to make any extraction and the reconstruction of everything. So we worked with it with the multidisciplinary dentistry, and I think it's very important to collaborate with different specialties. So first of all, what we did, we started with ortho treatment, and what we tried to make is the extrusion of this lateral incisor so the soft tissue will come with it. Okay, and that was what was happening. It was coming all that way, but the problem is that the crown she had at the implant was not permitting the tissue to come down with us. So we changed that crown and we placed a provisional. With that provisional, what we tried to do is to leave here some free space so the tissue will come with us. So we worked with it and we make the extrusion. See here how it has changed. We were cutting this zone so the lateral incisor could come with us. And after the ortho treatment, this was how it looked. It looked quite good because we have a real good advantage in this case. It was the length of these crowns. This is a great advantage that you can see at the beginning of the case, and just keep it for you. So when you finish with the treatment, maybe you can make some changes there, and the patient will be a little bit more happy. So what we did is only one surgery step, which was this. We tried to increase the crown length of these other teeth and modified the volume and the position of the soft tissue there. And we also knew that we didn't have enough volume there, so we went again to the tuberosity and bring some tissue there and place it on the same surgery. And this is how it looks when we finish with the surgery. And this is how it looks 10 days afterwards. So it looks quite good. So everything was fine, and we knew that we didn't have a great papilla there, but I think it was much better than what we had at the beginning. So we went on along with the case. We prepared some veneers for the central and the lateral, rounding the implant. We prepared our provisionals there. We polished there. This is how they looked. And the lab started working with the crown and the veneers. And once everything was done, this is the aspect they have when we remove the provisionals. Placement of the zirconia abutment, and this is how it looks when we finished. Okay, you can see the case and say, that's not perfect. I know it's not perfect. I know I don't have the same papilla here than here. Nothing to do. Okay, but the patient, she was really happy with the ending. And sometimes I think it's important to remember where we were coming from. The papilla was placed here. There was no tissue there. So with just one step of surgery, we finish with this situation. Sometimes what we'd like to do is the cases for us, just to do all the steps we'd like to do. But I think we have to try to make simple dentistry for our patients. And our patients are all the time demanding that. She was very proud of the results, so we finished with it. And everything is maintaining the situation real good. So this is the last case we have. So this is the last case I want to show you. She's another nice young woman with a really big aesthetic demand. She's got a problem here. She's got no papilla there, so we have to try to reconstruct everything again. But it's important to talk with the patients and see what they really want of the treatments we're planning. So I like to talk with them and sometimes draw lines on what they have at the beginning of the case. So I did it with her. And I told her that this was the starting situation, these are the lines, and this should be the papilla that we have missed. And also I told her that what would be perfect is to have this perfect ending. She said that's great, I want to do that. Okay? And I said, great, have to explain you what kind of treatments we're going to make. And I talked with her and I say, okay, we have to do the extraction of 21 hard tissue and soft tissue regeneration, ortho treatment, change the gingival festoon there, place an implant, the crown, and some veneers. So I tell her we have to do all kind of specialties in dentistry, all kind of treatments to get to that final ending. And she said, okay, that's great for me, but the problem is that I'm not going to do any ortho treatment, final modification of gingival festoon, nor veneers. I said, okay, if you'd say that, the problem is that I cannot get to that perfect ending. And even though, if you say that you will, maybe we cannot do it. She said, okay, just let's start with the case and see what happens. And whenever we finish, once we've finished, we'll see if we have to make any changes more or not. So we started with the case, and this is the X-ray we have. You see that there's a problem with the bone here, the distal zone. And I know we can talk here of how to do this case, and everyone will say a different way of doing it. Maybe we can make the extraction and the implant placement on the same moment. We can do that. I think it will go great. But in this case, I prefer to walk with 2 steps. Just first of all, make the reconstruction of everything, and once we've done it, just place the implant. So we worked with that. So we made the extraction, and at that moment, we made also a hard tissue regeneration with a non-reabsorbable membrane. I don't like making any kind of flap in the anterior zone, no discharge, so there won't be any aesthetic problems. So we place a non-reabsorbable membrane between the hard and the soft buccal tissue there. And we also used connective tissue graft, but it was not free. It was a pedicle connective tissue graft, which was coming all the way from the palatal zone to the alveolar zone. So we brought it that way, and we placed the non-reabsorbable membrane on the palatal zone, covered with the connective tissue graft, which was introduced on the buccal zone there. So this is kind of difficult for me to explain it in my language, so even though in English is much more difficult, so I'll try to place a video, so I think it would be easier to understand the way we did it. Oops. Sorry. That's the way we make the separation of the hard and the soft tissue in the buccal zone. connective tissue graft with the Husserl technique. But the difference is that we don't take it free. We leave it pedicled here in the mesial zone. Then we create a tunnel which goes from the alveolar to the connective tissue we've just prepared. So it will come all the way there. We use some sutures so it will come easily. Here it comes. We put some puros. And we introduce the non-rupturable membrane on the palatal zone. And in the second step, we do the same with the connective tissue graft. We introduce it in the buccal zone. So the membrane is covered and established because of the connective tissue. We don't have to make any suture or anything to stabilize the membrane. The connective tissue will establish it. The problem now is the healing. What I was saying was the problem was the healing now. Because you know that non-rupturable membranes, they work real good when they're not exposed. But if they're exposed, you're dead. So this is 11 days afterwards. You have to wait. You don't have to think that you have to wait 10 days. Maybe it's 11, 20, 30, whatever you need. But just go on watching the different colors of the tissues there. You see 11 days, 18 days, 22 days. That's good. That's a moment. You can take them out and prepare the first provisional. That's a provisional which is not gonna make any pressure to the tissue. We're just trying to copy the other one. And we're trying to find some information that he will give you, okay? See how it will work months afterwards, and it will show you where the volume is missing. So if you see the lateral view, you'll see that you need more tissue here, in the distal papilla, where we knew that we needed. So we know that we've got a second surgery procedure in which we're going to place the implant. So we wait for it. We wait some months afterwards and see the X-ray, how it looks. Where's the tissue there? We've got a lot of bone there, and we've got a bone there in the lateral incisor, so we know that if we have that bone, maybe we can gain some kind of papilla. So we make the second surgery, we take off the non-rupturable membrane, and then we've got bone enough to place the implant wherever we want to. We have no problem now. We can place it on the palatal zone, we can place it wherever we want to. And we can also use that moment for the placement of the second connective This is a free one. We're going to place it wherever we really need it, in the distal zone. That's important. We need volume there, so we go on to the second surgery then. This is how we started. If you've got that color in the non-resorbable membrane, looks good. If it's white, good. Brown, real bad.
Distant sounding voices choose to look away, but I need something to keep me alive, feel from the inside. Driving on empty, right alone, I'm praying to an angel that says go on. It's not that easy when you're lost, you want to be lost. I hear your name, it opens up my eyes, leads me back to a day when we wore no disguise. I was yours and you were mine, and lost was a game. I have no sense of time when I hear your name. Stumbling in circles, afraid to feel, lost in the madness, know it's even real. I can't stay here, it's too cold. Where do I go? Now your name, it opens up my eyes, leads me back to the day when we wore no disguise. I was yours and you were mine, and love was a game. I have no sense of time when I hear your name.
So we did have enough stability for the implant placement and immediate loading also. This was the first provisional. There was no pressure to the tissue. We did work a lot with about 3 provisional till the ending of the cases. So this was the lateral view after the immediate loading, how the volume was looking there was quite good. This is the final restoration. You can see here the color, the texture was real good. The lab worked real good with this case. And this is what everyone was waiting for, how the papilla was working. Pink aesthetics. This is how we ended. And maybe you can see it better here. This is how we started. Remember, it's important to understand where we were coming from and how we ended with the case. So we know, again, more the same as the other case, we don't have the perfect finish, we don't have the perfect papilla. What we have is something which looks like more or less a papilla, but she was very happy again with the final restoration. I said, okay, let's move some teeth, let's make some ortho treatment. And she said, okay, when you started, you told me to draw lines. Why don't you do just the same? So we draw lines again. And she said, why don't you compare the final with the initial? And this was the comparison between one and the other one. So she was pretty happy with the result, and I think that I was too. So this is the ending of the case, the ending of the lecture. Thank you very much for your attention. Enjoy your day.